last week we spent time discussing a lot of the sort of genetic cardiomyopathies, the different presentations of heart muscle disease, hypertrophic, dilated, restrictive, the non-dilated LV cardiomyopathies, etc. Now, this session would be on the utility of cardiac MRI in inflammatory and infiltrative myocardial diseases. So myocardial dysfunction that is basically due to myocardial inflammation, which may be acute or chronic, and then myocardial infiltration. And then we will go into we'll go into detail in each of these patient groups and disease groups. So first of all, because, it's a cardiac MRI talk, we sort of describe the protocol we need. So for these patients, we want to establish their volumes, because getting a robust assessment of cardiovascular volumes gives us a validated and the most accurate assessment of ejection fractions, right and left ejection fractions, as well as even atrial volumes and function. So the basics is that we establish, we get our Hasten localizers, from which we develop our pseudo views, and then our short axis stack, from which we develop our long axis cine stack. And that way, we've achieved our volumes, and then we do the same. We sort of do a dedicated RV stack for right ventricular function, which is relevant, especially in the genetic cardiomyopathies. Then we do tissue characterization. And essentially what we want to achieve is T1 weighted images, T1 relaxation time, T2 relaxation time, but also to also get the maps of this, because from a sort of physics and the accuracy perspective, we know that the maps are actually more robust than just doing the weighted images. So we get T1, T2 maps, then we could do T2 star weighted images and mapping, and then we do our gadolinium imaging. So this is the contrasts. Gadolinium-based contrast agents are used in cardiac MRI imaging, and basically from gadolinium imaging, there are sort of 2 or 3 factors and indices that we derive, that we look at to actually help us diagnose the patient and answer the clinical question. The first is that we can basically test how the myocardium responds to the infusion of gadolinium. Now, gadolinium is, a substance that when infused through vessels, goes in with the blood flow into the bed of the myocardium. And if it is healthy myocardium, there's a predictable wash into the myocardium and wash out time. And therefore, we know that at a specific stage of imaging after the infusion has gone in, we expect the myocardium to be filled with gadolinium. And at another stage, at another time point, we expect the myocardium to not have gadolinium. If it's healthy, it should have washed out of it. And, it will probably be in the venous system going into the rest of second pass perfusion through the body. Now, we know that in certain disease states, especially if you have expanded extracellular space, then the gadolinium washing and washout time is delayed because it hangs in the extracellular space. And therefore, if we then have myocardium that has normal bits and bits that have expanded extracellular space, as seen in scar or acute inflammation, then at that time point that gadolinium should go in, it would have gone into the healthy myocardium. But if the blood supply is reduced in certain areas, it might not have actually gone into unhealthy myocardium in some areas, e.g. like in coronary artery disease. And then at the time point where myocardium should have washed out, which is our late gadolinium imaging, we would expect normal myocardium to be black, and because it's washed out and the myocardium is back to being nulled. But we would expect unhealthy myocardium, or myocardium that has lots of scar in it, to still be white. Now, it may not just be scar, there may be other substances that also expand extracellular space, but essentially, we expect areas of expanded extracellular space to still have myocardium hanging around at that late time point imaging. Now, one of the questions that came through from prior sessions was, at what time do we do late gadolinium imaging? Basically, the physics will allow you to do it anytime between 10 minutes after infusion to 20 minutes. It really shouldn't be earlier than 10 minutes because it's not late enough to ensure that healthy myocardium has washed out, and it really should not be later than 20 minutes. because that's too late and you may miss unhealthy tissue because they may have washed out as well. So generally at the different centers I've worked, some people do it at 10 minutes, some people do it at 15 minutes, but it's usually around that. Now, our post-contrast T1 maps help us in estimating the extracellular volume, because if we do a pre and a post and apply a specific formula, which has the hematocrit PCV of the patient imputed into it, then we can calculate how big the extracellular volume is. And, in the myocardium, and, we expect it to be less than 0.32 to 0.35 in most healthy people. And as it increases, it just tells us how much extracellular space expansion we have. And that is a strong index in certain disease states that we would see. So we'll start with acute myocardial inflammation. And it basically means that the myocardium is inflamed acutely, i.e. it has happened recently. Now, most of these patients will present, to the front door with chest pain. That may sound like your traditional angina chest pain. They may have constitutional, other symptoms like fatigue. They may have a low-grade fever if it's of an infective cause, and they usually would have EKG changes. And therefore, usually the diagnosis at the front door is that this is an acute coronary syndrome. So these are, sort of infographics from ESC guidelines on the management of chest pain and the section on MINOCA. Now, recently at cardiology academic meetings, there's been a lot of talk on MINOCA, INOCA. MINOCA basically means myocardial infarction with normal coronary arteries. INOCA means infarction or inflammation with normal coronary arteries, and some people call it ANOCA, which is angina with normal coronary arteries. And effectively, it just means that this patient presents, and we think they present and tick all the boxes from a patient's symptom perspective of what we expect in acute coronary syndromes, which are due to coronary artery disease. But when we then screen their coronaries, we don't see obstructive coronary artery disease. A bit of plaque here and there is not enough. It's got to be stenotic for it to be responsible, for it to be the culprit for the presenting symptom. So we don't really see obstructive coronary artery disease, and therefore we wonder what's going on. Now, years ago, maybe 15 years and prior, generally what would have happened is they don't have obstructive coronary artery disease. It's not an ACS, or maybe this is an embolic ACS, i.e. the vessel was pinched, caused infarction, but is now recanalized. And we didn't really know how to manage these patients because, what do they have? We don't know. And generally, they were temporized. If their LV function is normal, some people gave them dual antiplatelets, some people wouldn't. It wasn't clear because no one really knew this was a disease condition. But then people looked into it and realized that these patients actually go on to do poorly in terms of cardiovascular outcomes over like a 5-year period. And, it's not a surprise in retrospect now. Yes, retrospect is 20/20 vision, but, if we didn't have a diagnosis, then we didn't treat the problem. And it's no surprise that the patients will do badly in the future. So if we focus on the slide, on the picture on the left of the screen, if we exclude obstructive coronary artery disease, then we need to basically consider ANOCA, INOCA, and then, further non-invasive testing is recommended. Now, we basically need to get a diagnosis for these patients. And, we will see on the right, so the left side of the screen now, we can see that MRI is recommended to make a diagnosis and also to follow up the patients in the future. So this is from the AHA-ACC currently, which basically is trying to say the same thing in a different sort of more algorithmic fashion. If we've got stable chest pain and suspect INOCA, then, effectively, we are saying that maybe we know that this patient doesn't have obstructive coronary artery disease because they've recently had a scan that ruled that out. We should really be considering, a stress test, CMR, and then we basically want to make a diagnosis. And, it has a class 2A recommendation in the AHA guidelines. So when myocarditis is one of the things that we could find out from this sequential investigation, because essentially patients with myocarditis who present with chest pain, lots of them have EKG changes. It will be central, sometimes it's crushing, it may or may not radiate, but most times it sounds like an ACS. I guess sometimes what makes us suspect it's not is that when you look at the patient's sort of constitution, they may not have CAD risk factors. And you may have a really young person who's never smoked, whose cholesterol is normal, but has these factors. Usually the troponin is elevated because troponin is a product. Troponin elevation is a product of myocardial myocyte necrosis, and whatever causes necrosis will cause troponin elevation. Now, the part of the reason why a lot of work was eventually done in this field was that it's not benign at all. Up to 12% of cases of sudden cardiac death in young people who, unfortunately the patients passed on, but they do have an autopsy, would find out that they do actually have myocardial inflammation. It has a varied etiology, which could be infective, it could be autoimmune. Every cardiologist's dreaded nightmare is giant cell myocarditis because, it's florid, they deteriorate in a very escalated fashion, and patients could go from well to needing a transplant urgently within 48 hours. Another factor, another contributor that is sort of generating myocarditis sort of more recently is checkpoint inhibitors. So these are chemotherapy agents that are sort of immune system checkpoint inhibitors. And a lot of them basically cause myocardial inflammation. And, I've had, I think, one or two cases where it doesn't, they're usually quite unwell with it, and they have a high risk of eventual deterioration and compromise because the inflammatory process is an immune reaction to the agents that they've had for their cancers, and it basically causes myocardial inflammation, and sometimes quite often conduction system that affects the conduction system. So they are at risk of sudden sort of complete AV dissociation, complete heart block with absolutely no response from the myocardium in terms of you don't have any ventricular rescue or junctional rhythm, because that junction is just so inflamed, and therefore patients can easily just die. So it's important that we find a way to sort of detect this early so that we can, support these patients with exactly what they need before they deteriorate before us. The presentations of myocarditis are, as on the screen. Quite a lot of patients will come in with chest pain and arrhythmias, and unfortunately, the fulminant causes will go ahead to have catastrophic heart failure in a long or short time frame. And, essentially, it's not a benign condition. It's not necessarily, a less threat to the patient's life and cardiovascular health than things like coronary artery disease. Now, at every stage of this disease process, they could completely recover. Obviously, if they don't die, they could completely recover. They could recover with residual myocardial dysfunction or even sort of subacute inflammation persisting for some time. A lot of patients that get diagnosed with dilated cardiomyopathy in their 6th decade of life and later actually have had myocarditis. Because you would expect that if it was a genetic dilated cardiomyopathy, they'll present earlier. So a lot of patients actually present late with dilated cardiomyopathy, may have had really bad myocarditis earlier in life. It does not necessarily mean that they don't have a genetic mutation that fostered that, because you'd wonder if this is a spectrum, why do some patients have minimal symptoms and fully recover? Why do some patients have chest pain and arrhythmias and fully recover? Why do some patients have the same thing but don't fully recover? This is where all the genetic influences determine the progression on how the patient evolves over time. Now, this is from the ESC's recent, the ESC last year, at ESC Congress last year, published the first inflammatory myocardial pericardial diseases clinical guidelines. And this is from it, and basically describes the strengths of our different multimodality imaging modalities in managing these patients. As much as we know that the MRI as a modality, cardiac MRI is much stronger than echo in some things. We cannot ignore the ease of access of echocardiography. Every patient can have a version, no matter how big they are or how unwell they are, you can get a machine to their bedside and put a probe to their chest. And we can see that echo is quite, good in estimating function and volumes, but MRI is probably stronger. But when you get into the tissue characterization, that is where MRI is complete king, because echo can probably estimate that there's a scar using some, tissue assessment, novel tissue assessment tools like strain and Doppler. Echo can probably tell you there's edema because you can literally see that the myocardium is thicker, and you can see that there's some tissue differences compared to where it's not edematous. But it's now eye of faith and eye of experience that can tell that. But MRI can tell you that without a doubt, completely accurately and reproducibly. MRI can also give you an idea on all that inflammatory reactions that are going on, because we know that, when the myocardium is inflamed primarily, that inflammation can extend into the pericardium. And also when the pericardium is inflamed primarily, it can extend into the myocardium. Hence the terminology of myopericarditis and perimyocarditis. Slightly confusing, but essentially the nomenclature informs us that the last version of the word is the primary focus of inflammation, and the first bit is where it's extended into. And therefore, myopericarditis is a pericarditis that's extended into the myocardium, and perimyocarditis is the inverse. But MRI can categorically tell you that, because we can see pericardial inflammation, we can see effusion, we can even see, we can test the characteristics of the fluid if there's substantial amounts to put a region of interest over, because we can then tell if it's like plain fluid with or likely exudate with fibrin and all that, because the T1 characteristics will all be very different. Now, in the advanced sort of chronic stages, when patients progress from acute to subacute, some people never quite resolve their inflammation, again, because of their genetics. And their immune system. Some people may progress to chronic pericarditis at risk of constriction and sometimes even calcification. Now, in that stage, MRI takes center stage again, because we can actually see constriction. If we do free breathing acquisition of sinus, you can actually see the ventricular interdependence. We can also see that's a tethered myocardium plastered onto the pericardium, because if we were doing a cine and we put the tags on the MRI, we should be able in health to see that the pericardium is gliding over the myocardium and is moving differently. But obviously, if they were both inflamed and now plastered onto each other, then they're all moving together. And you can see that on MRI. And this is where echo is wonderful, and I would always do and read echoes, but MRI is stronger. So this is from the same guidance. I hope it renders slightly bigger on your screen, but basically it's trying to put together all that I think I've said in the last couple of minutes. So I'll just go down to where my cursor is, which is basically saying when the patient presents and you want to rule out obstructive coronary artery disease, first of all, look at your echo, EKG, biomarkers. They'll probably all be elevated, to the same degree. You can argue that a troponin in the hundreds, high sensitivity troponin in the hundreds is less likely to be a big infarction. Let's put it that way. It could be an infarction. It could actually be a STEMI, depending on when you catch it, but it's less likely to be sort of a proximal LAD full thickness infarction, especially one that stays in the hundreds. But myocarditis goes well into the thousands, and ACS is staying in the hundreds. So, it's not really erudite in telling us which it is. Now, we would want to see the coronaries to decide on whether they're obstructed or not. Depending on your index of suspicion and what is available, you could take them to the cath lab, shoot the coronaries, and in 20 minutes you're done. Or they could have a CT coronary angiogram, which will give us the same answer, basically. Now, if we think, having ruled out obstructive coronary artery disease, the diagnosis now is MINOCA, depending on how they've presented, or ANOCA. really we should be putting them forward for a cardiac MRI scan because we'll be able to say what the diagnosis is. If people have come in with typical symptoms, elevated troponin, they have and normal coronary arteries, non-obstructed coronary arteries, they have myocardial inflammation of unknown cause. Now, it could be acute myocarditis, it could be Takotsubo, stress cardiomyopathy, so these are the factors that we would want to tease apart with cardiac MRI, and we are grateful that it can actually give us that information. And then, depending on what they do have, they may actually need further investigations. They may need PETs, nuclear testing. They may need electroanatomical mapping to guide their ablation if they are very arrhythmic and need that urgently. So, eventual therapies really for these patients depends on what we get out of a cardiac MRI. And, there's been a shifting paradigm in the diagnosis. So previously, almost 20 years ago, the aim was to get everybody to have endomyocardial biopsy because if we get a piece of the myocardium, put it under the microscope, we will tell you if it's inflamed and what type of inflammation. Is it, largely macrophages and sort of chronic? Is it largely lymphocytes? Is it largely neutrophils? But endomyocardial biopsy is one, not risk-free at all, especially in a very unwell patient with inflamed myocardium. You have a much higher chance of rupture and causing more harm than intended good. And therefore, it was not necessarily ideal, but that was what we had at the time. Then MRI comes onto the stage and we put both together because we really did not have as robust protocols as we currently do. And therefore, a bit of this and a bit of that. But now we can actually use it interchangeably, and very, very few people in any part of the world still get an endomyocardial biopsy for myocarditis. The people that still do are patients that are fulminant and, are rapidly deteriorating, not responding to therapies, and you want to basically decide on whether you're giving them high-dose biologic steroids. It's basically the patient with giant cell myocarditis, to be totally honest. Now, the Lake-Lewis criteria is basically what we use to diagnose myocarditis, and it's entirely, to be honest, dependent on cardiac MRI. Lake-Lewis, because that was where the meeting held for the first, when they put it all together first in 2009, and then it's been updated in 2018 as we have more robust protocols now. Professor Ferreira at Oxford is, basically the has done a lot of work on myocarditis, leaping on a lot of work that Professor Friedrich and McGill had done prior. So he sort of authored the first criteria and Professor Ferreira authored the second. And effectively what we're trying to say is, if we have the patients that we've described and we offer them a cardiac MRI, if we have two MRI indicators, then they have myocarditis, and that's the diagnosis. And what are these indicators? A T2-based criteria and sort of a T1 based criteria. Essentially, one criterion is looking out for myocardial edema, and the other criterion is looking out for non-ischemic myocardial injury. So edema is all about T2 weighting, because if we go back to session 1, we did say that our T2 time was, indicative of edema, right? So elevated T2 relaxation times or T2 maps that show global or regional increased intensity tell us there's myocardial edema. Then the next criterion that we want to check for is there evidence of a non-ischemic pattern to myocardial injury? Now, we detect myocardial, injury heals by scar formation, basically, either diffuse interstitial scar, fibrils within the myocardium, or complete replacement fibrosis where there's been myocyte death and the myocytes go away and are replaced by collagen bundles and scars that form a distinct scar. Now, we can test that with T1 mapping or T1 weighted images, ECV assessment, and leg gadolinium enhancement. Remember, T1 is elevated if we have scar within the tissue, because as the magnetization is going back to its null position, the time with which it goes back is extended if it has a lot of fibrils in there, versus if it's just pure myocardium and healthy. ECV, we've just discussed how we do it, and essentially extracellular space is expanded if we have scar, because that is what is extracellular space, right? Collagen. And obviously, leg gadolinium imaging direct assessment is again looking out for that expanded extracellular space by how much gadolinium hangs around in abnormal tissue versus normal tissue. Now, the supportive criteria are then if we see pericarditis, if we see pericardial inflammation, which, depending on how good your images are, we could see it in the T1 weighted images, but largely LGE is what we depend on because it's the most robust of the tissue characterization protocols. And also things like, systolic left ventricular dysfunction, regional wall motion abnormalities, abnormal global function as supportive. So it's like to make a diagnosis of myocarditis, really, it's cardiac MRI dependent. And effectively, this is how they've translated this updated Lake Lewis into the guidelines from last year, basically saying it, we need T2 weighted imaging or mapping. Maps are more robust than the absolute just images. And, these are the parameters we put in our reports. And remember, we are assessing both the myocardium and the pericardium. T1, the same thing, and basically elevated T1 tells us there's diffuse fibrosis, and then late gadolinium enhancement, we will see distinct scar, which is replacement fibrosis, and then cine imaging for regional wall motion abnormality and function. And this is how we put it all together to decide on whether there's myocarditis. And basically, this is what we see in different disease conditions. With myocarditis, we would see that there is elevated, these are T1 maps, these are T2 maps, T1 maps, like gadolinium imaging, and we can see that. But we'll see some sort of patient pictures that tell the story. So this is actually a patient I was involved in their care about 3 years ago. 21-year-old gentleman had some gastroenteritis. There'd been a festival in the summer, as there is in the United Kingdom, and he'd had some gastroenteritis for a few days, was lingering. He felt poorly and rough with it, had a bit of a low-grade fever. But the reason he comes to hospital is that in the last 24 hours, he's had chest pain, central heaving, and also palpitations. Then, surprise, surprise, his troponin was not normal. It was, quite elevated, certainly not normal. A cutoff is about 14 for high sensitivity troponin. So this is certainly abnormal and indicates myocardial inflammation. However, this gentleman should not have obstructive coronary artery disease because he's 21. His cholesterol, lipid profile was normal. He didn't have a family history of premature CAD. But even if he did, he's still 21. It's early. But he didn't, and therefore his pretest probability of obstructive CAD was quite low. His EKG is shown, and apart from some fractionation in lead 3, QRS fractionation in lead 3, biphasic T waves in V3 and 4, it's not startlingly abnormal and certainly does not demonstrate ischemia or raise suspicions for ischemia. That's actually his echo. And we can see that we would expect a 21-year-old to have more robust LV function. Visually, I'd say that this is probably 45 to 50% at best. And we can argue that that septum is not really moving as well, but the lateral wall is quite, hypokinetic. Then he gets a cardiac MRI scan, and what do we see? So these are T1 maps on top and T2 maps below. And if we peer closer, that's sort of your color bar telling you the numbers. Now, for our scanner at the time, normal T1 time was basically 950 to 1050 milliseconds on our 1.5T Siemens scanner. Now, 950 to 1050 is somewhere between purple and the start of orange. And we can see that the septum and anterior wall and inferior wall are certainly a different color from the lateral wall. And remember, on that echo, that lateral wall was quite lazy. It wasn't moving as much as the others. They weren't all normal, but the lateral wall was quite hypokinetic. So T1 time on the anterior septal and inferior wall is actually normal, but on the lateral wall, it's not. Now, T2 time, basically for our scanner was about 45 to 50 milliseconds. And again, it should be about, purple going into red, which his anterior septal and inferior walls are, but then the lateral wall is quite brilliantly yellow, quite elevated. So that, and I think the T2 time here was as high as 60 milliseconds. It was distinctly abnormal, as was the T1 time. So, we know that there is infiltration within the myocardium. It may be interstitial fibrosis, or it may just be inflammation. And with T2, we are quite confident that this is edema. So if we go back to that, and then we look at the late gadolinium images, and we can see that the rest of the myocardium that had normal T1 and T2 time also nulls nicely and is black. So gadolinium has washed into this myocardium and washed out, but the lateral wall is hanging onto the gadolinium because it has expanded extracellular. It's basically inflamed. So you see, we then meet the criteria, 2 out of 2 of our criteria for diagnosing myocarditis as per these guidelines, because we have abnormal evidence of myocardial inflammation and evidence of myocardial injury. So he has myocarditis, and actually we cultured Clostridium difficile in his stool and its antigens in blood. So this was sort of C. difficile mediated myocarditis. Because it's 21 and a lot of patients get in contact with C. difficile, have the gastroenteritis, but don't proceed to myocarditis, we actually offer them genetic testing. So this is basically what we expect from, cardiac MRI of a patient with acute myocarditis. The most important thing to say is that if we think a patient has acute myocarditis and we want to do a cardiac MRI to diagnose, we have to do it in a timely fashion, because we have to remember that this is acute and, the immune system may burn it out and dispose of it, and the inflammation may settle. And therefore, if it's 6 weeks after our index episode, the yield falls remarkably. The yield of making a distinct diagnosis is well reduced after 6 weeks of the index episode, because inflammation in most people would have settled, and you can't be categorical at that point. So really, they need to have it soon. Yes, I think I've said this. Now, the benefit of cardiac MRI is that in the patient who has a substantial event, we could also repeat in 6 months' time, like we did for this gentleman, because, his LV is not normal. We're supporting with guideline-directed medical therapy, offered him genetic testing, but we also want to see that his heart has recovered, so that if he hasn't, we can do other things. Right, time is skipping. So I'll just touch on chronic myocardial inflammation. And to be honest, the poster child for this is cardiac sarcoidosis. It's a chronic inflammatory cardiomyopathy is due to non-caseating granulomas getting embedded in the myocardium. We know that this is most likely the body's immune system response to an external antigen, and data on it, research on it suggests that people who have been exposed to a lot of what do we call it? A lot of foreign antigens. So maybe people who have worked with a particulate matter, silicon, people who have worked in fires, like firemen and all that, could have this, where the body, there's a lot of influx of external antigens, and the body tries to mop it up by forming these granulomas over it. And some people would go on to just sort out the disease and clear it out. But obviously, depending on each person's immune system constitution, they may never clear the antigen successfully, and therefore they have persisting nodules within their myocardium. The problem with this is that inflammation persists, and depending on where the granulomas are, it may interrupt the conduction system. They're at risk of arrhythmias, and patients often present with conduction disease. So a young person coming in heart block should always raise the suspicion for cardiac sarcoidosis. They may come in with arrhythmias or indeed resuscitated cardiac arrest. We know that for some reason there's a threefold in sort of the US National Database study, where you have people of different ethnic origins, and people of African ancestry had the highest prevalence, and then women of African ancestry had even high, like within that, had a higher prevalence. We generally say that it's the master masquerader. It could present with or as anything, and therefore it's just that index of suspicion. Now, historically, again, 10 years and before ago, the idea was to get tissue biopsy, because these patients are treated with biologics, and before you expose a patient to biologic agents, you have to be certain that that's the diagnosis, because there are risks of giving people steroids for a long time at high doses and other biologic agents. Now, the problem with cardiac sarcoidosis is that it's usually a patchy disease process, and therefore, if you just go in with an endotome to do your biopsy, you may just get normal myocardium. And in fairness, the yield from endomyocardial biopsy is atrociously low. and is known and is less than 30%, which means that we don't have a diagnosis, and therefore we end up treating the patients on a presumption with which there's a bit of guilt, because what if they don't have sarcoid, or we don't treat them when we could have. Now, cardiac MRI, fortunately, has excellent sensitivity and specificity for the detection of cardiac sarcoidosis. And basically, the patterns that we could see is, our workhorse for detecting sarcoidosis is basically we're looking out for late gadolinium enhancement in a non-coronary fashion. So it doesn't go along a coronary territory. So you could have just focal inflammation, focal enhancement in the septum. You can have extensive subepicardial enhancement. You can have RV only enhancement. You can have this hook sign that involves the anterior and the septal walls of the left ventricle, but also goes on to involve the right ventricular apex. And this is sort of quite specific for cardiac sarcoidosis. And further work has suggested that, the more foci of enhancement a patient has with cardiac sarcoidosis, the worse their outcome, unfortunately. So basically, our protocol is as described, and we basically want to assess function, but most importantly, like gadolinium enhancement. T1 and T2 mapping are sort of surrogates. They don't really tell us yes or no in any specific way, but it's actually the presence and extent and pattern of enhancement, like gadolinium enhancement, that clinches the diagnosis. So I'll describe this gentleman, who is a real patient, by the way. This was last year. He's presented this way and actually was a resuscitated cardiac arrest. This was because he was sort of in incessant ventricular tachyarrhythmias even after he'd been resuscitated. So we see that this is unequivocal ventricular tachycardia going really fast, probably at about 200 beats per minute. And that's his sinus rhythm EKG. So you see, if this man came to the clinic a week before saying, oh, I'm a bit short of breath and I have some palpitations here and now, the EKG we would have had is this one on the right. And it really just shows sinus rhythm. There's a bit of fractionation of the QRS complexes, but nothing is jumping out at us. But, he's able to do this. Now, this is just an axial slab of a non-cardiac CT he had, because he was too unwell to have a cardiac CT. But as this slab goes through, and we are just looking at the coronaries as they come off, we can't really see any coronary artery disease. We see his arteries quite well, and he doesn't have coronary artery disease. So we know that if we see late enhancement on his MRI, it's not from coronary artery disease. And he had a dedicated CT coronary angiogram elsewhere as well. His echocardiogram is, basically unremarkable. There might be a bit of septal hypertrophy here, but apart from a reduced ejection fraction and reduced strain, again, nothing is jumping out at us. He then has his cardiac MRI. We can see the sinus at that time. He had an ICD implanted because he was so rhythmically unstable. We can see that we have normal chamber sizes. Function is definitely not normal, but is like, mildly impaired, 45 to 50%. But then look at his late gadolinium images. We have distinct large foci of enhancement, and this is scar really. Subepicardially in his anterior wall from the base to sort of the mid-distal cavity, and also subepicardially in the inferior wall. And we can see that the septum here has a lot of late enhancement. So this pattern, it's not in a coronary distribution. We know that he doesn't have coronary artery disease. So this is non-ischemic cardiomyopathy presenting with tachyarrhythmia, resuscitated cardiac arrest, and multiple foci of late enhancement. Is, we put it all together and we think he has cardiac sarcoidosis. So we start him on therapies. Now, because we also do, metabolic imaging with FDG PET, it's important to then test if those foci are actually inflamed, because it's late enhancement, this is scar. But then if they are inflamed, then he stands to benefit from biologic agents to damp the acute inflammation. And that's the sort of strength of sort of multimodality imaging and hybrid imaging, because we can see that whilst his anterior wall scar is FDG avid, which shows that there is metabolic activity. This is alive. This is probably inflamed. His inferior wall scar is actually FDG silent, so it's probably not inflamed, and all the inflammation is around here. And this is probably where his tachyarrhythmias are being generated from. And we know that, from people who have done some work on this, and this is from Dr. Blankstein's group at Brigham. And essentially, if patients have a combination of a perfusion defect, which is a scar on their FDG, and also FDG uptake, that these patients, if they do have a scar, as well as active metabolic activity, they have worse cardiovascular outcomes, especially survival-free of tachyarrhythmias. Basically, they are much more likely to have ventricular tachyarrhythmias or indeed die. And this is just a diagnostic algorithm that's been put forward recently to, highlight the strength of hybrid imaging and how it helps us categorize our patients. So myocardial infiltration, we will go into. So we're sort of changing gears. And, whilst we've discussed patients that have inflammation in their myocardium, we will now be discussing patients that have infiltration, where external substances find their way into the myocardium, get embedded, and alter how the myocardium functions, and therefore alters cardiovascular outcomes. Now, this is sort of me rewarding the first slide that we had last week when we discussed hypertrophic cardiomyopathy. We would describe LV hypertrophy as patients having increased LV wall thickness, which is more than 15 millimeters in patients of African ancestry, or more than 13 millimeters in patients of non-African ancestry, because generally, we know that people of African ancestry have more wall thickness that is still normal. So we have that 2 millimeter gap to accommodate the genetics. Now, a sarcomeric gene mutation is present in 40 to 60% of patients with LVH, but that means it's also absent in 40 to 60% of people with LVH and hypertrophic cardiomyopathy. Generally, most people who come in with symptoms, maybe an abnormal EKG that shows left ventricular hypertrophy and an echo that shows concentric or asymmetric LV hypertrophy, will have a diagnosis of hypertrophic cardiomyopathy placed on them. But strictly speaking, we think we sort of refer to that, especially as per the ESC guidelines recently, that hypertrophic cardiomyopathy is for those patients that have a sarcomeric, i.e., that sarcomer that we sort of looked at. So if they have a gene mutation in one of these constituents, then they have hypertrophic cardiomyopathy. If they don't, then they have left ventricular hypertrophy, and we need to find out why they do have that. So here comes the mimics. What are those disease conditions where people have LV hypertrophy, EKG abnormality? Because obviously the ECG tells us about repolarization, and polarization of the ventricles will be abnormal if there's thickness. It could also be abnormal in a different way depending on what is causing the thickness, but LVH does not make the diagnosis. LVH by voltage criteria on ECG doesn't make the diagnosis. So we have these mimics where they don't have the gene mutation. There's nothing wrong with their sarcomeric proteins, but they have left ventricular hypertrophy. What could they have? MRI in this case will help us decide what they have. So phenotype the patient accurately, because what they have determines what they should get. It also helps us determine the stage of the disease. Are we at the early stage of this disease? Are we at the late stage, burnt out stage? It also helps us define their risks of death and adverse cardiovascular outcomes. Again, it's late gadolinium enhancement that helps us. It's really the workhorse of interrogating the myocardium, because that's what has been shown in every disease condition to have a linear relationship with adverse cardiovascular outcomes. The more the LGE, the worse the outcomes. And I think I mentioned in our slide, the last week or the week before, that most Kaplan-Meier curves on late gadolinium enhancement and its prediction of adverse outcomes look the same. Patients without late gadolinium enhancement experience outcomes in a gradual, low slope fashion. Patients with late gadolinium enhancement experience worse outcomes, and we'll see a few of those Kaplan-Meier curves. And the more the LGE, the worse the outcomes, the higher the occurrence of adverse outcomes. So cardiac amyloidosis is basically one of the mimics because here patients have LV wall thickness, but it's not due to sarcomeric mutation. It's actually due to some misfolded proteins that get deposited in the myocardium and basically infiltrate the myocardium and keep infiltrating depending on their concentration circulating in plasma. They cause perceived hypertrophy because the thickness is more, but they are also known to be toxic to the myocardium. So take, for example, AL amyloid protein is known to be directly toxic. So they will also cause local inflammation, local scar formation, and progressive myocardial dysfunction and heart failure. There's about 40 known amyloid proteins. Generally, AL and TTR are the ones that one most common, but also known to cause cardiac disease, myocardial disease. TTR is, however, quite common in patients of African descent. And, traditionally, you can make the diagnosis when you get tissue from affected organs. And then, a typical histology question in medical school where, you put it under Congo red, put it under the microscope, prepare the tissue, apply Congo red staining, and you should see that apple green birefringence. But that assumes that you have tissue and that you have tissue from an affected organ. But what if you don't? And not everybody would be able to undergo biopsy or in the specific organ. So, non-invasive assessments, if proven to be robust, would actually be really helpful here. And cardiac MRI does help, when put together with other things. And therefore, this is a paper from the ESC's Working Group on Myocardial Diseases. And basically, suspect if you have LVH. Now, generally, it uses, because this is out of Europe and their cutoff is 13 millimeters, remember, for LVH. But in practice, for an African or someone of African descent, what will be applied in clinic will be 15 millimeters and above will be deemed abnormal. So if there's LVH with one red flag scenario, and I'll highlight this in the next slide, what the red flag scenarios are, then you think about amyloid. Now, the first thing is to sort of do non-invasive testing. So, because AL and TTR are the most common now, AL is a cancer, is myeloma, and TTR is this is basically a non-malignant condition. Their treatments are very different, and that's why it's really important to know which is which. The first thing is the non-invasive testing with, serum and urine immunofixation and electrophoresis to see if we actually have excess free and excess kappa and lambda light chains, free light chains. Because if we do, then it's most likely AL and our algorithm goes down a different path. But if we don't, then it could still be, TTR or indeed AL, but we haven't picked it up. And then cardiac MRI and bone scan become your next investigations that help you define what the patient has. So the red flag features are if they have heart failure that you can't find a cause for, apart from this abnormal looking LV function and wall thickness, if they have aortic stenosis, if they've ever ruptured tendon, biceps tendon, if they have bilateral carpal tunnel syndrome, macroglossia and all that, also tongue macroglossia is also one of the red flag features. If they have peripheral polyneuropathy, orthostatic hypotension, these are the things that make you suspect. But also the EKG, if a patient has such hypertrophy, you expect them to have tall voltages to meet, Sokolon-Leon for LVH by voltage criteria. But then suspect TTR amyloid if a patient has hypertrophy but actually has muted voltages, very low voltages. Because remember, it's not muscle hypertrophy. It's actually because these proteins have infiltrated the myocardium, so they don't conduct electricity as thick as, a congruent to their degree of thickness because they are proteins. They are not actually myocytes. So you actually have decreased voltages, very low voltages on the ECG. So basically, this is that flow chart. If you suspect it, offer them. This is out of the ESC's recommendation. Offer them a bone scan and a hematologic test. The bone scan, may not be freely available or easily available in our climate in sub-Saharan Africa or in low and middle income countries. Hematologic tests we certainly can do serum and urine, electrophoresis and immunofixation. But a cardiac MRI would actually help us because, cardiac MRI would demonstrate features typical for amyloid, whether it's AL or TTR. It doesn't really differentiate. But, it would help you make the diagnosis that this is amyloidosis, and therefore the patient can then go with that established diagnosis if they have access to specific center where they can then go and do scintigraphy and all of that. And if scintigraphy, if the scintigraphy is negative, but their hematologic tests are positive, then it's AL. If scintigraphy is negative, but hematologic tests is also negative, and they have an abnormal cardiac MRI that is indicative of amyloidosis, then it's probably TTR. But obviously, before patients eventually have definitive, precise therapies, we would need to be certain of which type they have. But it helps the patient to know what's wrong, to know where to seek help, especially when we don't have large ivory tower institutions that are capable in precisely refining phenotypes. So this is, echocardiography in a patient with amyloid will basically show us hypertrophy. We can notice that the longitudinal motion is reduced, and usually tissue velocities are quite reduced, like less than 5 centimeters per second. We usually have this cherry on top strain pattern where you have reduced strain at the base and mid cavity level and preserved strain at the apex, because that's sort of how the deposition occurs. MRI, we want to basically acquire these different sequences because each one gives us an idea, basic sort of localizers haste cines will show us that there is increased wall thickness, LV hypertrophy. The volumes may be elevated or normal, but function is usually reduced. We can perceive that reduced longitudinal motion. You can check the AV plane displacement and it's reduced. And if you have capabilities for MRI strain, it will have a similar strain pattern as the echo. T1 times are elevated because of that deposition. And then when we do a TI scout, which is inversion recovery, i.e. when we apply a saturation pulse, how long does it take the myocardium to recover to its usual position? There's usually a pattern where the blood pool recovers first before the myocardium, but in cardiac amyloidosis is actually reversed, and the myocardium may recover at the same time as the blood pool, i.e. go black at the same time as the blood pool, or even go black earlier, depending on how much amyloid has deposited in it. LGE tends to show extensive enhancements because, but the problem with amyloid is that the LGE never looks right because it's difficult to null that myocardium because it's just completely infiltrated. And actually doing the extracellular volume assessment is more reliable because you don't apply things like LGE burden to amyloid because you don't really know where's LGE and where's myocardium. Everywhere looks really white. We'll see a case. But extracellular volume, you can reliably quantify, and then it's actually being used to track response to therapy in TTR amyloidosis. So this is MRI. So we can see the cines. We can see that this LV is, wall thickness is concentric and it is quite thick. And I think when I measured, it was about 24 millimeters. So certainly abnormal. Now, if we look at the long axis, we can see that the base and mid cavity are not really contracted, and there's minimal longitudinal motion here, but the apex, just seems to be doing a bit more. And that's sort of what contributes to that strain pattern you eventually see. So we can see that the hypertrophy is quite global, effectively. It's not asymmetric, it's from the base to the apex, there is hypertrophy. And this is the pattern, myocardial nulling. So basically, if we follow, we can see that the myocardium turns black before the blood pool. It turns black before the blood pool, simply because there is actually a lot of, why is this flipping? Simply because there's actually a lot of amyloid. We would go on to diagnose amyloid in this cardiac amyloidosis in this patient. I think I was trying to go slower. You can see the myocardium turns black before the blood pool. So we null the myocardium before the blood pool. And then when we do the late enhancements, we can see there's a lot of gadolinium enhancements here in the sort of this infralateral wall, the septum. But actually, as we scroll through, doesn't really show here, but actually there was a lot around the mitral valve annulus, interatrial septum. We have a bit in the RV endocardium, and this is basically what cardiac amyloidosis looks like on the gadolinium enhancements. So this is some of the work from Professor Mariana Fontana, who leads the National Amyloid Center in UCL London. And basically, we're saying that in patients with AL versus ATTR amyloid, patients with TTR amyloid have a lot more transmural LGE than subendocardial. AL patients is basically equivocal. And, we can see that their extracellular volume expansion increases depending on how much LGE they have, because, they're actually surrogates of the same thing. And these are those Kaplan-Meier curves I was referring to that, for every Kaplan-Meier curve that looks at the impact or the predictive ability of late gadolinium enhancements on, predicting adverse outcomes or cumulative survival. Or actually, when you retrospectively review patients, you will find out that the patients without late gadolinium enhancements always do much better than the patients with late gadolinium enhancement. And in the patients with late gadolinium enhancements, the patients that have more late gadolinium enhancement always do worse. So basically, blue curves don't have LGE, green curves just have subendocardial, and yellow or gold curves have transmural. And we can just see the rapid attrition in survival such that in 40 months, you just have about 40% of patients still alive in the people that have transmural LGE. And such is the, in fairness, tragic survival in TTR amyloidosis, which is why, thankfully, there's been a lot of research in it, and we now have therapies. We have silencers, we have tafamidis, we have things that, we can give these patients and hopefully try to reverse or slow down these curves. In fairness, we are more likely to achieve what will be perceived as success or more success if we diagnose patients earlier. Because if patients have scar, i.e., actual collagen scar, you can't recover that. You can, retard how much amyloid is in their myocardium, but scar can never be reversed. And therefore, we sort of want to get patients before they get to that irreversible heart failure stage with lots of myocardial scar. Quickly touch on Fabry disease. Fabry disease is Anderson Fabry because there was two of them working at it at the same time, one in London, one in Germany. They described the disease, same disease, sort of within 2 months of each other, more than a century ago. But effectively, it's one of those X-linked disorders where it's a lysosomal storage disorder where we have glycosphingolipids get deposited in body tissues. Now, it's due to deficiency in alpha-gal A, which is an enzyme that breaks down these glycosphingolipids. So because you don't have the enzyme that is breaking them down, they all accumulate. And these are the forms, GB3 and the global triacyl sphingosine that just accumulate in tissues. And we know that they could accumulate in the heart, the kidneys, the skin, the muscle nerves, but largely heart, kidneys, and skin. It's rare, quite rare. But the good news is that this accumulation can be halted by enzyme replacement therapy, because remember, it's an enzyme deficiency. If we can give the patients that enzyme, then we don't have the accumulation. Now, most times with systemic diseases that have a cardiac manifestation or involvement, outcomes, especially, hard outcomes like life and death, is determined by the degree of cardiac involvement. It's the same with, systemic sarcoidosis. It's similar with systemic amyloidosis, and Fabry disease is not an exception. The cardiac involvement is actually what determines, how or when people die. And it's usually progressive where, if we had the benefit of following up a patient, we would see that the first factor we would notice is sort of LV hypertrophy, abnormal T1 time if you did an MRI at the time. And then we have fibrosis, and then we have progressive heart failure, and then intractable arrhythmias and heart failure. Now, we will suspect Anderson Fabry disease if we have a patient that has left ventricular hypertrophy and echocardiogram with lots of hypertrophy in the papillary muscle, abnormal strain, but also much more importantly, a family history that suggests an inherited condition. And what is that? It's a family history where people are experiencing something in the same organ system at every generation. So great grandfather had something, grandfather had something, father or mother had something, and then this person. So it could be heart failure, it could be renal disease, but once we see something that is going through the generations, then of course we think it's inherited. And then if we do a pedigree of the family, if we see it seeming to go through the X chromosome, and therefore, a grandfather has something, and then that grandfather's daughter has something, and then that daughter's son has something. The chromosome they all share is the X chromosome, not the Y. So that is really what it's like and this, it's an X-linked disease. Yeah. So because these are glycosphingolipids and they deposit in the myocardium, and we said in session 1 that fat has a short T1 time, right? So if sphingolipids are deposited in the myocardium, it will shorten the T1 time of the heart. So you then have LVH, where you would expect that this is normal T1 or even high if there's diffuse interstitial fibrosis, but then they have really low T1 time. And, you suspect Fabry's disease essentially. And this slide is basically telling you, if you did an echo of these 3 patients, it will look exactly the same. But the patient with hypertrophic cardiomyopathy may have normal T1 or elevated T1 slightly if they have fibrosis, interstitial fibrosis. The patient with amyloid will have distinctly elevated T1 time, and the patient with Fabry's disease will have distinctly reduced T1 time. And basically, that's our protocol. Basically, we want to do CNS for volumes, parametric mapping, tissue characterization with T1, T2, and LGE. We also want to do the post-contrast to get our extracellular volume assessments. And, we could assess valves if valves are abnormal. So that's it said differently here. And then this patient. So real patient again, sort of one of my favorite. Well, this I presented at an international meeting, but essentially it was interesting because this is sort of the power of multidisciplinary team and also having an integrated inherited cardiac condition service, because we were seeing this patient's mother in the service, seeing them. And generally, when patients come in with left ventricular hypertrophy, we offer them cascade screening. We say, oh, your children, your first degree relatives, which is your children and your siblings, should have an echo and an EKG. So this lady tells her sons that they should have an echo and an EKG, and she has 2 sons. And, one of the sons is not in our catchment and one of the sons is in our catchment and comes to clinic because they had an echo and EKG at our center and they actually have left ventricular hypertrophy on EKG, which we can see with the abnormal repolarization of T-wave inversion. And they also had an echocardiogram that demonstrated left ventricular hypertrophy, but they were well. They were a young person living a normal life, has a bit of skin rashes for which he sees the dermatologist and has some topical creams, but that's it. He's a well person, unlimited exercise tolerance, happy. Now, as we go through the family history, now, a bit of this is in retrospect because, this patient was in our clinic as a patient with left ventricular hypertrophy, hypertrophic cardiomyopathy. Mother was gene negative, and obviously these are sarcomeric genes that are likely in the panel. And the cascade screening was done about 10 years ago. So the panel at the time was just sarcomeric genes, and mother was gene negative. So we're also managing the mother that way. And therefore, we didn't offer him genetic testing because, if the proband is gene negative, you don't offer the other members of the family because you don't really know what you're looking for. So we just managed, we're seeing him at intervals doing his ESC risk score. He never scored high on the risk score. He never had palpitations or arrhythmias on protracted EKG monitoring. So we just followed him up. Now, over time, mother went into atrial fibrillation, which is not uncommon in hypertrophic cardiomyopathy patients, and also was getting lots and lots of palpitations and non-sustained VT. So in the passage of time, our panel had now expanded to include the storage diseases. So we then tested her alpha-Gal A activity, and it was very low. And we then offered up, specific gene testing for the gene and saw that she bore a mutation, and therefore her diagnosis changed to Fabry's. So we went through her case at a multidisciplinary meeting and said to, right, she is a woman, she's giving her sons the X chromosome. So we reinvited this gentleman to clinic sooner than his usual 2-yearly visits, and he was still fine. Now, this was about 6 years, I think, from the initial MRI that he had, and we offered him another MRI. Now, with the benefit of the insights from mother's most current gene testing, and the fact that we now had parametric mapping, because parametric mapping hasn't always been there, especially sort of the T1, T2 maps. So with the benefits of advancing technology and CMRI protocols and science, as well as a bit more information into the specific family, we took another family history again. Obviously, family history is like, it's almost like what they say about the computer, garbage in, garbage out. The patient's answers to the question is, the yield is as rich as the questions you ask them. So now we're going to a detailed multi-generational family history. And then it's like, oh yeah, grandfather sort of died. He had renal disease early in life, sort of in his 60s or 50s, but also had heart failure and eventually died from both of them in his 70s. They didn't think it was abnormal because a 70-year-old person having multi-organ disease is not necessarily premature. But anyway, we then looked at this. This was a CMR from 2017. This is late gadolinium enhancement. We don't really see a lot of enhancement convincingly. But we repeated this, and we can see that there's now a bit of enhancement in the lateral wall, as seen on the short axis and long axis images. Then we do his tissue characterization, and this is his T1 time. It was about, I think, 840 or 850 milliseconds, distinctly low. So we were able, on this cardiac MRI, to say that his diagnosis was Fabry's disease. Yeah, 859. We're able to say that it's Fabry's disease and basically referred him to the Lysosomal Storage Diseases Center at University College London, where he's there having an enzyme replacement therapy. So I think, this case sort of highlights the fact, one, to always review the cases that we have in our sort of patient pool. If we have more insight in the science, we should translate it back to the patients we're looking after. And if things change, we should sort of reinterrogate our initial conclusions to be sure that we're still offering the patient the best. In retrospect, when we then looked through his dermatology biopsy from that, it was actually angiokeratomas that he had, and angiokeratomas are a known skin manifestation of Fabry's disease. I'm going to quickly touch on cardiac iron deposition disease because it's also an infiltrative disease. It's excess iron in the myocardium. It usually occurs in one of two groups of patients, either patients that have a primary hemochromatosis or patients that have excess, a lot of parenteral transfusions due to transfusion-dependent anemias. Because obviously the patients are anemic, but they may not necessarily be iron deficient, but each time we give them blood, we give them iron, and eventually they start depositing. And that's probably more topical to us, our clients, where we have sickle cell disease, and thalassemias, and also other tissue transfusion-dependent anemias. The strength of T2 star mapping is that basically we're testing for iron deposition in the myocardium, and it's been validated, and we know that certain thresholds actually correlate with the amount of iron in the myocardium. And iron reduces, shortens T2 recovery, essentially. It shortens the time such that, in a patient with iron overload, we can see that the times are lower. Where am I? Where's my cursor? The times are low, and usually if you have a T2 start time of 10 milliseconds or less, then you have severe myocardial iron overload. And it's the importance is that we can then, if patients are already have sort of maybe a genetic transfusion dependent anemia, we can actually at intervals do their cardiac MRI and assess their T2 star times. And once it starts shortening, we know that, they are having myocardial ion deposition and they actually should be referred for chelation therapy, because we know that the amount of iron in their heart muscle will determine their myocardial dysfunction, and myocardial dysfunction will determine their overall outcomes, even from the systemic disease itself. Yeah, so these are what we expect to find in, severe iron deposition disease in the heart muscle. So I think, in summary, what I've tried to describe is how, to be honest, cardiac MRI in the current day is indispensable in offering precision therapy to our patients with non-ischemic heart disease. The diagnostic yield of cardiac MRI could be equivalent to endomyocardial biopsy, as demonstrated with the myocarditis. We know that LGE is a strong predictor of disease burden, but also disease stage, because like the Fabry's disease patient, he initially didn't have LGE, but after some time he had LGE, simply because the disease progressed, because we hadn't really dealt with the primary problem here. So we can actually stage the disease, and that also helps us prognosticate different stages better, and also helps us offer specific therapies that make the most difference at every stage of the disease. And I think that, putting together the fact that there is a problem to be solved, and we have tools like cardiac MRI to solve it, as well as, the internet, digitization, it means that we can actually build and expand cardiac MRI programs across the nation, across the continent, and we can always lean on this bilateral and, multifocal stakeholder engagement to actually offer our patients what they require. Thank you very much, everyone.